Hello, my name is Dr. Robert Rozbruch at the Hospital for Special Surgery. What I'm going to talk to you about today is preoperative information for ankle distraction arthroplasty surgery. So this is really intended to be a preoperative educational information session for a patient who's about to undergo ankle distraction surgery. Ankle distraction arthroplasty surgery, or commonly known as ankle distraction surgery, is a joint preservation procedure that we do to treat ankle arthritis. Most of the time the arthritis is post-traumatic in nature, and these are people who have pain in their ankles, they have maintained mobility in their ankle, and they really are looking for a treatment option that does not require fusion of the joint or replacement of the joint. Fusion is a good operation, but it has a lot of disadvantages. Namely, you lose mobility, and it also causes abnormal forces and can create problems in the future. And ankle replacement surgery also, while is a very good operation for older people, is not the ideal operation for the young person, and also has a number of contraindications. So ankle distraction surgery is a joint preservation surgery that is intended to treat ankle arthritis. There are a few components to the procedure. One is actually opening up the ankle joint in most cases and cleaning out the arthritis. What does that mean? What I typically do is open the joint. There are usually bone spurs that are blocking mobility in the joint, and I usually remove those bone spurs, and in that manner I'm able to clean up some of the arthritis. The second part to the procedure is identify areas of the joint that have full thickness cartilage loss, and I make small little drill holes in the surface of the bone to allow the bone marrow to come to the surface. And that's a technique called microfracture. That is a technique that helps regenerate cartilage in the ankle joint. The third part of what we do is we obtain bone marrow aspiration concentrate. We obtain bone marrow aspirate concentrate from the patient while they're in the operating room. We concentrate the bone marrow, and in that fashion we are able to obtain mesenchymal stem cells. Those stem cells have the ability to enhance cartilage regeneration. So we inject those cells into the ankle joint as well. And finally, we apply an external fixator that is used to distract the joint, to actually pull apart the tibia and the talus. In most cases, in some cases we're pulling apart the tibia, talus, and the calcaneus, so that we're distracting the ankle and the subtalar joint. And in some cases we're only distracting the subtalar joint, depending on the location of the arthritis. But the combination of opening the joint, cleaning up the arthritis, performing microfracture, injecting stem cells, and then creating a distraction space, an actual space for the cartilage to regenerate, is all very important, and these are all the components of the procedure. Distraction in and of itself enhances cartilage formation, but when we combine it with these other biological aspects of the procedure, we're really doing a comprehensive approach to joint preservation. When we apply the external fixator, we usually place it so there's a hinge in the device, which means that the ankle can continue to move even while it's in a distracted position. Patients can bear weight while they're in the ankle distraction frame, and even though you're weight bearing, the tibia and the talus do not compress against each other and still allow space for cartilage regeneration. Our results with this technique have been very, very good. 90% of our patients have had a satisfactory amount of pain relief from the ankle distraction, have had a satisfactory amount of cartilage regeneration, and have not needed to have any other procedures such as ankle replacement or ankle fusion. So the operation is done with a regional anesthetic, which means that general anesthesia is not necessary, but patients are completely comfortable and don't feel anything. The actual surgery typically takes about 2 hours. 1 hour is for the open part, where we approach the joint, and the second part is applying the fixator. The blood loss during the surgery is minimal, so patients do not typically require a blood transfusion. The hospital stay is usually 2 to 3 days. During that period of time, there's some physical therapy in hospital. The patient will get up and start learning how to walk. They'll learn how to unlock the fixator and start doing the ankle range of motion exercises. And they'll also learn how to do the pin care, which starts on postoperative day number 2. After leaving the hospital after the second or third day, I usually see people back 2 weeks later for the first postoperative visit. During that time, I obtain an X-ray. I look at how the ankle looks and see how much distraction there is, even with a weight-bearing X-ray. I typically will give an additional 1 to 2 millimeters of distraction just by making a small adjustment of the fixator that's painless during the office visit. I will typically prescribe exercise program at that time. Again, I'm usually suggesting that patients unlock the fixator 4 times a day and do the range of motion exercises. The second follow-up visit would be at 4 weeks later or 6 weeks after the surgery. Typically check things again, usually do an additional millimeter of distraction, and then the following visit would be the removal. The total time that the patient has to wear the fixator is 10 to 12 weeks. After the fixator comes off, which is done as an ambulatory surgery in the operating room, they will typically wear a cam walker boot for a period of approximately 2 to 6 weeks and really progress weight bearing and progress activities and physical therapy as tolerated. The actual surgery is not very painful. During the hospital stay, you'll be on a PCA, a patient-controlled analgesia pump. So the pain level will be minimal and very well controlled. Usually on the second postoperative day, patients are transitioned to oral pain medications, which control the pain very adequately. It's very typical that people will take a low-level narcotic, something like Vicodin or maybe a Percocet, for approximately 2 to 4 weeks. And we really encourage people to wean off of it from there. You'll be able to get up and start walking the day after surgery, partial weight bearing, using crutches. Patients will typically use crutches for the entire time that they're in the frame, but performing partial weight bearing, putting some weight on the leg, and being quite mobile. Well, it usually takes about a full year until patients really reach that 100% mark, but much of the recovery happens much sooner than that. As I mentioned, at 3 months the fixator is removed, and probably a few months after that patients are feeling much better. Certainly daily pin care. The pins have to be cleaned on a daily basis. There is a regimen for doing that. We teach you how to do that. Daily shower is fine, and it's also a great way to keep your pins nice and clean. And finally, the exercise regimen. We teach you how to unlock the fixator and perform range of motion exercises so that you keep your ankle moving. When we're preserving the ankle joint, we're doing it because we want to preserve the motion. That's why we want to avoid a fusion. And so we want to maintain the motion, and that motion may be maintained even while you're wearing the ankle distraction frame. This is a typical ankle distraction patient who is able to put weight on the frame. Notice that after the ankle distraction is done and in the fixator, patients are really able to walk, put weight on the leg. Using crutches for some balance is typical. So this is a nice example and a typical example. This is an example of the patient performing the range of motion exercises by planting the foot on the floor and really pushing the knee forward. And you notice that it's a great way to really do the range of motion, and at the same time the ankle still maintains its distraction. That's an important component of this. You unlock the fixator and you just dorsiflex, pull up and down on the ankle. Hi, how you doing?
Good. How are you?
Good to see you.
Here, sit up.
Sure, absolutely. That was comfortable. So it's been about 6 weeks since we did the surgery to distract the ankle.
Yes.
And your X-rays look really good. I'm going to show them to you.
Okay.
How's it been going with your motion? Are you unlocking the frame? And
Yes. So far, so good.
Good. Let me have you demonstrate a little bit of how you do the motion exercises. So pull up and down and up and down. That's great. So I like the way you're doing that. You're pulling up, pulling down. Do you use the green strap?
So I use the green strap.
Okay.
And then I get somebody else to help me kind of lean or near down a little bit.
Right.
Or I got the
So the idea is like really giving it a good pull.
Hold.
And then and
Back
then
down.
and then down. So you're really keeping the ankle moving. I love it. And as I'll show you on the X-ray, even though you're moving the ankle up and down, it's in a distracted state. And now you're getting well beyond neutral, which is great. There's no equinus, and so that's really good. And moving the ankle a little bit while you're walking, that's really good. Okay? And another good way to do the exercise, take this foot and move it forward, push it forward.
And
Plant it like that.
kind of like open a little bit like this, and then
You can
rock
exactly
it
just rock
like
back and
that.
forth. That's really good. You're getting a really good stretch on the ankle when you do that. The X-ray before surgery shows that you've got really complete loss of cartilage, bone rubbing on bone here in the front of the ankle, right? And then what you see here on this X-ray, obviously you see the fixator and the pins, but what you really see, you see carefully, you can really see the space in the ankle. You know, you got a nice big space in the ankle here, and that's with you putting weight on the leg for the X-ray. And that's where the cartilage is regenerating. These are the bone spurs that we cleaned off in the front at the same time. And then this is this needle into the distracted joint. That's where we injected the stem cells.
I haven't found any place else that does this. It's good to know that there's somebody out there looking out for people that still want to walk. Because I got a lot of years left, and not being able to walk is unthinkable.
So, any questions?
So far, no.
All right, my friend.